Welcome to today's course, and we'll start with cardiac glycosides with our digoxin or lanoxin. Cardiac glycosides are medicines that are used for treating heart failure and certain irregular heartbeats. So generally, we use them to treat atrial fibrillation, atrial flutter, and congestive cardiac failure. Digoxin has this positive ionotropic effect. They increase the cardiac output, and they also have this negative chronotropic effects where they decrease the heart rate and can cause bradycardia in your patients. So again, with our negative or with our ionotropic agents, we have our negative ionotropic agents and our positive ones. So the negative ionotropic agents weaken the force of muscular contractions, while our positive ionotropic agents like your digoxin can increase the force of cardiac muscular contractions. With our chronotropes, you can have a positive effect where they increase the heart rate, or you can have a negative chronotropic effect where they decrease the heart rate. So again, digoxin has both a positive ionotropic effect and a negative chronotropic effect where they decrease the heart rate. With digoxin, they are a common cause of poisoning. So we need to monitor and maintain our ranges in a therapeutic level. So the therapeutic levels for digoxin should be between 0.8 to 2.0 nanogram per mil. So the patient goes into a toxic levels when your digoxin levels are above 2.4. So you want to look out for that. And what will be, how will you know your patient is going into digoxin toxicity? Gastrointestinal upset is the most common symptom of digoxin toxicity. So you're going to see those GIT symptoms like anorexia, nausea, vomiting. Patients could also report visual symptoms. They classically present with this yellow-green discoloration, or they tell you they have this yellow vision. You would also see cardiovascular symptoms, most especially heart blocks. Remember, with bradycardia, we're talking about heart blocks. So again, you would see heart blocks. You could also see palpitation. They could have difficulty breathing. And you would also see neurologic symptoms like confusion, drowsiness. They could be hallucinating. So again, you must teach your patient to report these symptoms, especially those early symptoms of digoxin toxicity, like your anorexia, the nausea, the vomiting. And with digoxin, you must check the apical pulse. You must check your apical pulse before administering digoxin to your patient. So we want to hold digoxin if the pulse is less than 90 per minute in infants and young children, or if it's less than 70 per minute in older children, or if it's less than 60 in adults. An elderly client with depression, diabetes, and heart failure has received a new digoxin prescription for daily use, which client assessment indicates that the nurse should follow up on digoxin levels frequently. Okay, do we need to follow up with an apical heart rate of 62? Remember, you want to take an apical heart rate for a full minute before you administer. And if we have an apical heart rate of 62, then that is fine. We can go ahead and administer, so we don't need to follow up with this. How about the blood sugar level of 240 milligram per DL? Well, an elevated blood sugar level requires attention, but it's unrelated to digoxin toxicity. Although hypokalemia can increase the risk of digoxin toxicity, but again, we won't need to follow up with this, even though we need to pay attention or to address the high blood sugar. How about the client taking our SSRI? We talked about SSRI previously, an antidepressant drug, fluoxetine, or your Prozac. Again, this does not interact with digoxin, and 20 milligram is a normal dose, so we don't need to follow up with this. But look at this serum creatinine. Remember, we said create. You want to remember God created the world. It started from 0 days to 7 days. So that's how I remember my creatinine level, 0.7, and then I double the 7 and I get 1.4. So again, that's my normal digoxin range. But look at this. This is above normal. And that tells me something is happening with this guy's kidneys. And again, with decreased kidney function, it could lead to, we know digoxin is actually excreted by the kidney. So if the kidneys are not functioning as they should, it could cause the client to retain more digoxin, and that could lead to digoxin toxicity. So we'll need to follow up with digoxin levels frequently with option number 4. The home health nurse visits a client with atrial fibrillation. We said we use this, we use cardiac glycosides, our digoxin, to treat atrial fibrillation, atrial flutter. We said we also use it to treat congestive cardiac failure. So this guy has been prescribed, so again, newly prescribed digoxin. Which of the following client statements show that teaching has been effective? So when the patient says, I need to call the healthcare provider if I have trouble reading, does that tell me teaching has been effective? Yes, remember we said clients with digoxin toxicity can present with visual problems like sensitivity to light, or they have this yellowish halos around light, or they complain of blurred vision. So if he says this, then that tells me he's understood the teaching. So I'm going to select that. If the patient says, I need to check my blood pressure before taking medicine, again, we need to check the heart rate, not blood pressure. So I'm going to eliminate this. We don't need to check the heart rate before taking our digoxin. If the client says I should call the healthcare provider we said nausea and vomiting are those early signs of digoxin toxicity. So you see those GIT symptoms, anorexia, nausea, vomiting. So again, if he says this, that tells me he understood the teaching. How about number 4? I should check so we already said that you want to check the your heart rate, your apical heart rate, and again for an adult, if it's less than 70, you want to withhold the medication. So this tells me he understood my teaching. And if he says I should call the healthcare provider if I feel dizzy and lightheadedness, again, this could be signs of those neurological symptoms we talked about. So we said the patient could have neurological symptoms like confusion, drowsiness, headaches, and hallucination. So I'm going to select option 5, and those would be my correct answers. So remember, with digoxin toxicity, there could be those gastrointestinal symptoms. In the initial period, you could have nausea, anorexia. We said you could have neurological symptoms like your confusion, the drowsiness, the dizziness. And then we said he could also present with visual symptoms like those yellow halos around lights and the blurred vision. Okay, so the nurse is performing discharge teaching for the parents of a 4-year-old with heart failure. Which statement indicates the need for further teaching related to the digoxin administration? Okay, so if the parent says, if our child vomits after a dose, we won't give a second dose, well, that is a good, that is good. We shouldn't repeat the dose. So that would be good. We won't need further teaching. How about number 2? Symptoms of nausea and vomiting should be reported. Okay, so we said this could indicate early signs of digoxin toxicity. So if she says that, we don't need to carry out further teaching. How about if she says we would hold the dose if our child's heart rate is above? So that would be wrong. We would only hold the dose if it's less than 90 for this child. So again, that would be wrong, and we'll need to carry out further teaching. So generally, the guidelines are to hold digoxin for pulses that are less than 90 in infants and young children, and less than 70 in older children. So again, they don't need to hold these doses. We'll need to carry out further teaching. And if she says we will not mix the medication with other foods or liquid, well, that would be a good one, because if you've mixed it already and the child refuses to take the medication, then you wouldn't even know how much of the medication that has been ingested. So number 3 would be our correct answer. Let's look at immunosuppressant medications or immunosuppressive agents. They are also called anti-rejection medications. These drugs are used to inhibit or prevent activity of the immune system. They suppress inflammatory response, especially in autoimmune diseases like your rheumatoid arthritis, Crohn's disease, and even psoriasis. So what examples of our immunosuppressant medications? We have Adalimumab, Infliximab, and Etanercept. So these are your TNF inhibitors. They are called TNF inhibitors, tumor necrosis factor inhibitors. So your Adalimumab, Infliximab, and Etanercept. Those are our TNF inhibitors. There's also Tacrolimus, and Cyclosporine. These ones are mainly used to prevent rejection or attack of a transplanted organ by the immune system of the person receiving the organ. You know, people who have had like a kidney transplant, usually they are placed on Tacrolimus or Cyclosporine, and it's going to help to prevent rejection or attack of that transplanted organ. There's also our corticosteroids like your prednisolone or your prednisone. These also help to reduce inflammation and suppress the immune system. Again, when you start clients on immunosuppressant medications, you must instruct them on proper dental hygiene because of these medications can, they can produce what we call gingival hyperplasia. So you can see this drug-induced gingival hyperplasia, where you have overgrowth. So you can see how the gums tend to overgrow. Most times they can even completely cover the teeth, making it difficult to maintain effective oral hygiene habits. So again, we know that improved oral hygiene can often resolve this condition and it can even improve the symptoms. So you want to teach them about gingival hyperplasia, and also you want to teach them on how to carry out proper dental hygiene. With clients that are taking TNF inhibitors, if they have infection, they should not take TNF inhibitors. So remember, clients with infection should not take TNF inhibitors like our Adalimumab, Infliximab, our Etanercept, because these suppress the immune system or immune response. So we do not want to give clients with infection TNF inhibitors because it's going to further suppress the immune response to that infection. Before starting drug therapy, you want to test your client for tuberculosis because these immunosuppressive actions of your TNF inhibitors can activate latent tuberculosis. So again, before you start a patient on our TNF inhibitors or immunosuppressant medications like your Adalimumab, Infliximab, or Etanercept, the client should be tested for tuberculosis because the TNF inhibitors can activate latent tuberculosis. You also want to make sure your client receives the inactivated influenza vaccine, and this is going to help to reduce the risk of contracting the flu virus. Again, that immunosuppressive response needs to be taken consideration of because if we give them the live vaccine, it could cause a problem in this client. So clients taking TNF inhibitors, they are at risk for infections and they should avoid live vaccines. So with the flu vaccine, we want to give them the inactivated influenza vaccine. The nurse is assessing a client with rheumatoid arthritis who has been considered for Adalimumab therapy. Which statement by the client needs further investigation? So if the client says, I'm taking an antibiotic for a urinary tract infection, that means they are currently on that antibiotic. Again, if we are considering this client, we want to use Adalimumab therapy. You want to remember that Adalimumab, your Infliximab, your Etanercept, these are tumor necrosis factor inhibitors, and they suppress inflammatory response in autoimmune diseases like our rheumatoid arthritis. So due to that immunosuppressive action of TNF inhibitors, these clients taking these drugs at increased risk for infection. So a client with a current or recent or chronic infection should not take a TNF inhibitor. So this would require further investigation. How about option 2? I had a negative tuberculosis skin test 2 weeks. Again, that would be a good thing. Remember, we said the immunosuppressive action of TNF inhibitors can activate latent tuberculosis. So we want to carry out a tuberculin skin test before we begin TNF inhibitor therapy. And if the client tests positive for latent TB, they must undergo treatment for TB before starting therapy. How about number 3? I just received my yearly flu shot a week ago. Again, remember, clients taking immunosuppressive therapy like your Adalimumab should receive an annual inactivated influenza vaccine to reduce the risk of contracting the flu virus. Remember, they are at risk for infection and they should not receive live attenuated vaccines. And the last one, I will continue taking naproxen at night to help with the pain, okay? Again, because of the pain associated with rheumatoid arthritis, we can give them our naproxen or your celecoxib. Those are your non-steroidal anti-inflammatory medications, and it could effectively treat pain and minimize inflammations in this client with rheumatoid arthritis. So number one would be our correct answer. Now, with antipsychotics or neuroleptics, they are used to manage acute and chronic psychosis, principally in schizophrenia. So again, these medications are used to manage acute and chronic psychosis, especially with schizophrenia. They are also the mainstay, together with mood stabilizers, in the treatment of bipolar disorders. Again, we could have typical antipsychotics like your haloperidol, your fluphenazine. Those are our typical antipsychotics. You could also have your atypical antipsychotics like your Clozapine, your Risperidone, Olanzapine, Quetiapine, and Ziprasidone. Again, Ziprasidone is known for causing ECG changes like your QT prolongation. So again, those are your antipsychotics. Our typical antipsychotics are our haloperidol and fluphenazine. And your atypical antipsychotics are your Clozapine, Risperidone, Olanzapine, Quetiapine, and Ziprasidone. Ziprasidone hydrochloride. Again, with clients on these medications, you need to look out for extrapyramidal adverse effects. And one of them would be our neuroleptic malignant syndrome, or NMS. NMS is most often seen with antipsychotics. It's a life-threatening reaction to neuroleptic or antipsychotic medication that is characterized by fever, muscular rigidity, altered mental status, and autonomic dysfunction. And usually, the client could develop neuroleptic malignant syndrome just shortly after the initiation of a neuroleptic treatment, or maybe after the dose is increased. So you want to look out for neuroleptic malignant syndrome in your client that is prescribed haloperidol in the immediate, just shortly after you start the drug. Look out for fever, look out for stiffness, those muscle rigidity. Are there signs of altered mental status? I could tell you your client on haloperidol is going into neuroleptic malignant syndrome. Another extrapyramidal effect we would see would be tardive dyskinesia. This is actually caused by long-term use of neuroleptic drugs that are used to treat psychiatric condition. And what are you going to see? We're going to see this repetitive involuntary movement. So you'll notice the client grimacing and blinking their eye repetitively. You can even notice involuntary movements of the mouth, the tongue, their extremities. They have this chewing motion or sucking motion or thrusting their tongues out. That would be tardive dyskinesia, especially seen in clients with long-term use of antipsychotic or neuroleptic drugs. So again, stopping or tapering the drugs may be contributing to involuntary repetitive movements. So that can help to reduce those involuntary movements, which we refer to as tardive dyskinesia. So you want to either stop or taper the drugs off. We can also see pseudo-Parkinsonism, sort of Parkinson's syndrome. In these clients with who are placed on antipsychotic or neuroleptic medications, you will see shuffling gait. You would notice those rigid muscles. There will be excessive salivation. You will see tremors. They look like they are wearing a mask. They are walking, they don't swing their arms. You will see motor retardation. So again, benztropine would be used to manage these Parkinsonian effects in your clients who presents with Parkinson's syndromes or pseudo-Parkinsonism as a result of this antipsychotic medication. We could also see acute dystonic reaction or muscle spasms. Again, in the early period, you could see tightening of the jaw, stiff neck, their tongues could be swollen, and it could get worse as part of the late signs. So the tongue becomes swollen. You're already thinking about airway compromise in this patient if they present with acute dystonic reaction. You could also see oculogyric crisis. So you see those spasmodic movements of the eyeballs into a fixed position, almost like they are looking upwards. Again, with clients with antipsychotics, you want to look out for agranulocytosis because these medications can cause your white blood cell levels to be low. And again, this is life-threatening because of that severe and dangerously low white blood cell count. So they are prone to infection. So you want to look out for agranulocytosis, and because that would increase the risk of life-threatening infection in your patient. And with antipsychotics, we can also see orthostatic hypotension and photosensitivity. So again, you could see orthostatic hypotension and photosensitivity. The nurse working on the inpatient psychiatric unit is preparing to administer medications to a client. The medication record reads haloperidol, hydrochlorothiazide, acetaminophen, or omeprazole. On assessment, okay, the client is tremulous and exhibits muscle rigidity and fever. So again, I'm already thinking haloperidol, I'm thinking muscle rigidity, I'm thinking fever. Again, remember, we said our clients that are placed on haloperidol could go into neuroleptic malignant syndrome, where you would see those muscle rigidity, altered mental status, and again, we can see fever and even autonomic dysfunctions. So what are examples of autonomic dysfunction? They could be sweating, they could be hypertensive, they could be tachycardic. So again, I'm already thinking of neuroleptic malignant syndrome in this client. So let me look at my options. Which action should the nurse take? Give all medications, including, okay, so again, that would be wrong. Remember, we said on the NCLEX, if the client is in distress, you do not want to assess. We need to do something for this client, so we don't want to reassess in 30 minutes. This would be wrong. How about number 2? Hold their haloperidol, give us it. Again, we said we don't want to reassess, and even the time frame looks too long. In this client, we want to carry out an implementation option. How about number 3? Hold the haloperidol and notify the healthcare provider. Yes, the client is already exhibiting signs and symptoms of neuroleptic malignant syndrome. Treatment is usually supportive and directed at reducing the fever, reducing the muscle rigidity, and even preventing complication. Remember, these clients might require treatment in the intensive care unit. So the most important intervention is to immediately discontinue the haloperidol and notify the healthcare provider. Number 4, hold the haloperidol, hold the hydrocodone. Okay, so hydrocodone is a diuretic commonly used for hypertension. It does not cause NMS symptoms. So again, option 3 would be our correct answer. The nurse prepares to administer Clozapine to a client with schizophrenia. Which client statement will require priority investigation before administering this medication? Now, if the client says, okay, so because of time, I'm going to go with option 3, because if they say they're having a sore throat for 3 days and they're feeling feverish, we don't want to administer Clozapine. Why is that? Remember, we said Clozapine is a atypical antipsychotic, and it could cause agranulocytosis, which increases the risk of life-threatening infection. So again, we want to monitor for signs of infection in our clients, like fever, flu-like symptoms. So again, if my client is already having a sore throat and feeling feverish, I don't want to give that medication. Let's quickly look at opioids. Opioids are a broad group of pain-relieving drugs that work by interacting with opioid receptors in your cell. We could have our narcotic opioids like your codeine, your oxycodone. We could have our narcotic analgesics like our tramadol, our hydrocodone. You could even have your meperidine hydrochloride or our Demerol. So what are side effects you would see with clients on opioid medication? Again, there's going to be, it could cause sedation, it could cause dizziness, nausea, those GIT symptoms, nausea, vomiting. We could also see constipation in our clients. They could develop physical dependence or tolerance. You could also see orthostatic hypotension and even respiratory depression. So again, respiratory depression is a key one there because of that airway breathing compromise. Orthostatic hypotension is a key one there because of that safety issue. Remember, the NCLEX is more of a safety exam. So you want to pay key attention to safety issues. Again, You could see respiratory depression. The patient may present with a slowed breathing. So most times, if the respiration is less than 12 per minute, we don't want to give our opioids, especially with our morphine. Again, if we have an opioid overdose, our reversal agent would be to give Narcan or your naloxone. It's used to reverse the effects of opioid. It's commonly used to counter decreased breathing in opioid overdose. Again, remember with your Narcan, if the patient doesn't respond in 3 to 5 minutes, we can inject another dose. And you want to stay with the patient until the naloxone wears off for like 30 to 50 minutes after the injection. So again, I repeat, Narcan or naloxone is our antidote for opioid toxicity, and it's helped to decrease that. It's helped to counter decreased breathing in our patients. And if the patient doesn't respond, we can repeat another dose in 3 to 5 minutes. A post-operative client is prescribed IV patient-controlled analgesia with morphine. The client tells the nurse, I'm pushing the button, but I'm still having a lot of pain. What is the priority nursing action? Again, what's causing the pain? I don't even know. Would it make more sense to find out what's causing the pain? I think that should be what I need to do before I carry out an implementation. So option 3 would be my correct answer. I'll need to perform a thorough pain assessment. The client with cancer pain is prescribed Oxycodone. Which teaching is most essential to help prevent long-term complications? Again, we already said constipation is one side effect you can see with opioid medication. So number 2, I'll need to teach the client how to prevent constipation. So again, we said sedation, slowed breathing, they can develop dependence, they can develop tolerance, they can develop addiction. We also said you will see constipation, nausea, vomiting, all are side effects to our opioid medication. The client is taking morphine sulfate for acute pain. The client stands and is immediately lightheaded. So again, I'm already suspecting orthostatic hypotension in my client. What is the nurse's primary action? Okay, so my priority action would be to assist the client to a sitting position so that he doesn't fall. Again, I will need to carry out an assessment. Again, we said if the client is in distress, we do not want to assess. The post-surgical client is unresponsive to painful stimuli and is given naloxone. Within 5 minutes, the client is arousable and responds to verbal commands. 1 hour later, the client is again difficult to arouse with minimal response to physical stimuli. Which action should the nurse take? Select all that apply. Well, it wouldn't hurt to give oxygen. I'm going to go with that. I'll need to assess respiratory rate. That's a good nursing assessment. Okay, I don't need to initiate rapid response or call the cold team in. Rather, I'll need to notify the healthcare provider. And again, I can prepare a second dose of naloxone. Remember, we said you could repeat in 3 to 5 minutes. So many questions. So an elderly client is prescribed codeine for a severe cough. Okay, so codeine for a severe cough. The home health nurse teaches the client how to prevent the common adverse effects associated with codeine. Which client statements indicate an understanding of how to prevent them? Select all that apply. Again, we don't have photosensitivity. We don't see photosensitivity with clients with opioids or who are taking codeine. So I'm going to eliminate option 1. I'll drink at least 8 glasses of water. Again, because of that constipation and all of that, drinking 8 glasses of water would be indicates a good understanding. We need to avoid caffeinated, whether decaffeinated or caffeinated. Well, so this would be a wrong choice. I'll sit on the side of my bed for a few minutes. Again, we talked about those orthostatic hypotension, and I'll take my medicine with food. That would also be a good answer. So again, those are our side effects we talked about. Let's look at anticoagulants. So there are 2 classes of antithrombotic drugs. One of them will be these anticoagulants. The other would be our antiplatelet drugs. We know that anticoagulants slow down clotting, thereby reducing fibrin formation and preventing clots from forming and growing, whereas your antiplatelet agents prevent platelets from clumping together, and they also prevent clots from forming and growing. Like we said, anticoagulants, they're also called blood thinners. They prevent or reduce coagulation of blood, prolonging the clotting time. And one example of them would be our enoxaprine, which is a low molecular weight heparin. We also have heparin, There's dabigatran, rivaroxaban, and apixaban. Let's talk about heparin. Heparin blocks conversion of fibrinogen to fibrin. And you need to look out for heparin-induced thrombocytopenia in your client. You need to look out for thrombocytopenia in your client. What's thrombocytopenia again? Where the platelet count in the body is too low. How do you know your client is developing thrombocytopenia or heparin-induced thrombocytopenia? We're going to see petechia. So those small purplish hemorrhagic spots, those are your petechia. Again, the bigger ones are referred to as purpura. So that's how you know your client is developing a complication as a result of that anticoagulant. So again, look out for this serious complication if your client is taking blood thinners. So with heparin-induced thrombocytopenia, the immune system causes the platelets to clot in the presence of heparin, and that's going to result in your platelet levels drop. So we need to carry out complete blood cell counts to monitor our platelet levels. We need to carry out to monitor our red blood cells, to monitor our white blood cells. Look out for petechia, look out for purpura, look out for melena, look out for coughing up blood or your hematemesis, or even look at the gums, are they bleeding? So these are signs that your patient could be developing that complication. Heparin is an anticoagulant, and the priority concern when a client is receiving an anticoagulant is bleeding. So we need to monitor the effectiveness of our heparin therapy by monitoring the results of the PTT or our partial thromboplastin time. And the desired range for therapeutic anticoagulation is when the client is at 1.5 to 2.5 times the control without any signs of hemorrhage. So again, the lower limit of normal would be 20 to 25 seconds, and the upper limit of normal would be between 32 to 39 seconds. If we are giving our heparin, especially for IV administration, you want to use an infusion pump. You want to use an infusion pump. So we want to use an infusion pump. For injection, please never give IM. Never give IM because of the dangers of site hematoma. So again, never give IM. Rather, want to give it deep subcutaneously. And our antidote, if we have an overdose, would be to give protamine sulfate within 30 minutes. So we want to give protamine sulfate within 30 minutes. And for our enoxaprine, we said it's a low molecular weight heparin. It actually is less allergenic than the regular heparin. A client hospitalized with a diagnosis of thrombophlebitis, that will be a condition in which blood clots in a vein causes inflammation and pain. So it's being treated with heparin infusion therapy. After 24 hours after the infusion has begun, the nurse knows that the client's partial thromboplastin time is 65 seconds with a control of 30 seconds. What nursing action should the nurse implement? Remember, we said heparin is an anticoagulant, and the priority concern when your client is receiving an anticoagulant is bleeding. And we said we want to monitor the effectiveness of heparin therapy by monitoring the results of our PTT. And we said the desired range for therapeutic anticoagulation is 1.5 to 2.5 times the control. So here we've been told that the control is 30 seconds. And 1.5 times 30 should give us what, 45? And 2.5 times 30 should give us what, 75. And now they tell us the client PTT 65 seconds. So that falls within our range of 45 to 75. Remember, we said we want to have the client at 1.5 to 2.5 times the control. And this is what gives us the range. And if it's at 65, then that's a good thing. So let's look at our option. Do we need to discontinue the heparin infusion? No. The client is being heparinized well at 65 seconds. His PTT at 65 seconds. We need to prepare to administer protamine sulfate. Well, we don't have any toxicity. So we don't need to give an antidote. We need to notify the healthcare provider. Well, there's nothing to notify him of. Everything seems fine. We need to include in the report that the client is adequately anticoagulated. Yes, it is. 65 is within normal range. Let's look at Warfarin. So with Warfarin sodium, that will be an oral anticoagulant that is used mainly to prevent thrombotic events like our thrombophlebitis, or to prevent a pulmonary embolism or embolism formation, maybe as a result of atrial fibrillation. Warfarin, our Codeine, interferes with liver synthesis of vitamin K-dependent clotting factor. That's how it works. Codeine interferes with liver synthesis of vitamin K-dependent clotting factor. So again, one obvious adverse effect you would see would be hemorrhage. Again, with clients on these warfarins or oral anticoagulants, these oral anticoagulants prolong the clotting time, and we need to monitor their prothrombin time and also monitor the client's international normalized ratio. So again, the normal PT would be 9.5 to 12 seconds. Our normal INR would be 2 to 3. So again, one way I used to remember this is if I write P, T, T, all I need to do is increase this, and I'll continue this. So this is almost like HP heparin. So I remember that with PTT, I use it to monitor heparin medication. Whereas with my warfarin, I only need to monitor PT or my INR. So that's how I remember it. So when I write P and I write T and I write T, I just add this together and it reminds me, it's almost like I wrote heparin backwards, heparin. So again, that reminds me that for heparin, I monitor PTT at 1.5 to 2.5 times the normal. But as for warfarin, we want to monitor the prothrombin time and the INR. Also with INR, I see this as 1, and I write this as 2, and I write this as 3. So I know normal level should be 1. If you're on medication with warfarin, it should be 2 to 3. But again, most textbooks will say 3.5. But again, that gives you an idea. So our antidote for warfarin would be to give vitamin K. We can give whole blood or plasma. Remember, while we're giving vitamin K, we said warfarin or Codeine interferes with liver synthesis of vitamin K-dependent clotting factor. So again, even more vitamin K would act as an antidote to your warfarin. We also need to teach our clients to avoid venous stasis. We need to teach them measures to avoid venous stasis, like keeping their legs elevated or raised. That can help to reduce swelling and help to increase blood flow. Wearing compression stockings may also help. Regular exercise can also improve blood flow. So we need to teach them all of this. We need to emphasize importance of regular lab testing. And very important, you want to teach the client to avoid foods high in vitamin K. You want to teach them to avoid foods that are high in vitamin K. So clients should avoid foods that are high in vitamin K, like your green vegetables, pork, rice, yogurt, cheese, fish, and even milk. Remember, vitamin K is needed by the body to make clots, and warfarin blocks this process. So if you are eating too many foods rich in vitamin K, it's going to cause your warfarin to become less effective and cause more clotting in the body. So again, very important with warfarin, you need to teach them to avoid foods high in vitamin K. Other nursing consideration would be, like we said, we use warfarin in clients with the following conditions: with atrial fibrillation. Remember, with atrial fibrillation, the atrias are fibrillating, blood stasis, blood is pooling in the atrias, and that could cause the blood to start clotting. So we give them warfarin to prevent clot formation and also reduce the risk for a stroke, especially clients in atrial fibrillation at a very high risk for stroke. That's why we place them on anticoagulants like our warfarin and all of that, or heparin. Again, we also give clients anticoagulants, clients with deep venous thrombosis, and even clients with pulmonary embolism. Why? Because you want to prevent additional clots from forming. So very important to place these clients on DVT and pulmonary embolism. We need to place them on anticoagulants. Again, clients who have had mechanical heart valve replacements or hip or knee replacement surgeries, we want to prevent clot formation on those valves. So that's why we place them on anticoagulants. So you want to remember these conditions on the NCLEX with your anticoagulants: atrial fibrillation, deep venous thrombosis, pulmonary embolism, and again, heart valve, mechanical heart valve replacement surgeries. In these clients, you want to check for signs of hemorrhage. For example, are their gums bleeding? Are they having nosebleed? Is there any unusual bleeding? Look at their stools. Is it black or tarry? Is there blood in their urine? Again, look at their CBC. Look at their hematocrit level. Look at their blood pressure. Is there a drop in their blood pressure or a fall in their hematocrit level? That could tell you your client is bleeding. Look at do a Gaiac stool test. Is it positive? That tells you there's blood, there's occult blood in the stool. So again, we need to check for signs of bleeding in these clients. Clients should also avoid IM injection. Remember, we said hematoma could form. They also need to avoid aspirin-containing products and even NSAIDs, because these also could cause bleeding in your clients. The client should also wear medical information tags. You want to instruct the client to use a soft toothbrush when they are brushing. You want to use an electric razor, and this would prevent bleeding gums, petechia or bruising, or epistaxis, or even black tarry stools. We also want to monitor platelet counts. Look out for signs and symptoms of thrombosis, especially when they're on heparin therapy. And if you suspect heparin-induced thrombocytopenia, you want to immediately discontinue the heparin, and we can give a non-heparin anticoagulant. The emergency department nurse prepares a male client for surgery. The client was admitted with a traumatic open fracture of the femur. Now look at that hematocrit level. What does that tell me? So this is a male client, and the hematocrit level is 36. Again, I know for men, it should be between 38.3 to about maybe 48.5 or 6. So again, that tells me the hematocrit level is low. How about the hemoglobin? Again, for hemoglobin, I know with men, it should be at least 13.2 and above. So again, this client's hemoglobin level is low. The hematocrit level is also low. Usually, if I see low hemoglobin or low hematocrit, that must mean either the client is not producing enough red blood cells, or they are bleeding, or maybe there's something is causing an accelerated destruction of red blood cells. So this client is probably bleeding as we speak. And now they're asking me which prescription should I not validate before giving. I already see my heparin there, my low molecular weight heparin. This client is already probably bleeding. So again, we won't want to give enoxaprine. And again, if we are preparing a client for surgery, we should have stopped our anticoagulants like 12 to 24 hours before surgery. So please, you'll need to monitor our CBC, looking out for thrombocytopenia. Okay, so again, anticoagulants like your enoxaprine is used to prevent and treat deep venous thrombosis. Some side effects would include bleeding, bruising, injection sites, hematoma, and ecchymosis. Part of your nursing consideration, we said we want to give subcutaneously if we're giving it as an injection. Although it can be given IV during cardiac procedures, we don't want to use enoxaprine in patients with a history of HIT. We want to use it in cautions in clients with renal function or morbid obesity. Look out for signs of bleeding or excessive bruising. And again, we want to stop the medication 12 to 24 hours before surgery. The client is receiving a continuous heparin infusion, and the most recent APTT is 140 seconds. Again, this is already looking too high. The nurse notices, so those are signs of bleeding there. There's blood oozing at the surgical incision and even at the IV insertion site. My client is probably bleeding. So again, look out for those side effects like bruising and unexpected bleeding in clients with heparin. So this client is almost obviously bleeding. What intervention should the nurse implement, select, or apply? Okay, we don't need to continue this because the client is obviously bleeding. Well, we don't need to prepare vitamin K. So vitamin K would not be required here because we are using heparin. Rather, we'll need to administer protamine. So number 4 would be a correct answer. We don't need further assessment. The client is in distress, so we can eliminate this. We'll need to stop the infusion and contact the healthcare provider. So option 4 and 5 would be our correct answer. So again, your therapeutic APTT should be 1.5 to 2 times the baseline, and the baseline is between 30 to 40 seconds for patient receiving heparin. So again, I know we talked about PTT, but your APTT is the most commonly used test to monitor heparin in patients. Both of them are used to measure the same function, your PTT and your APTT, just that in APTT, the A stands for activated. So an activator has been added to speed up the clotting time and results in a narrower reference range. So the APTT is considered a more sensitive version of the PTT. And we said the reference range for your APTT is 30 to 40 seconds. Whereas for the reference range for our PTT should be between 60 to 70 seconds. Let's quickly look at the other class of antithrombotic agents, which is your antiplatelets. And we know that they prevent platelets from clumping and also prevent clots from forming and growing. There are medications that prevent blood clots from forming, and they work by stopping your platelets from sticking together. Examples of your platelets would be your aspirin or our acetyl salicylic acid and our clopidogrel, your Plavix. Obvious side effects of our antiplatelet would be same thrombocytopenia, where you're looking out for petechia, you're looking out for purpura, melena, hematemesis, bleeding gums. Again, thrombocytopenia will be that condition when the platelet count is low. The nurse reviews the medication administration records and lab results for assigned clients, which medication requires the healthcare provider be notified before administration. Again, calcium acetate for a client with a phosphate level of 8.5. So that's phosphorus there. Again, how do I remember it? Us. Phosphorus is like me and you. So that's 2. And 4. 4 sounds like 4. So that's 4. So again, that gives me an idea of what the normal ranges of potassium should be. Phosphorus should be, sorry. So 2.5 to 4.5. So I'm just going to add a 0.5 here and add another 0.5 here. And I know that calcium acetate is a phosphate binder. It binds to phosphorus and prevents it from being absorbed into the bloodstream. So if this guy is having a high phosphorus level, giving calcium acetate, which is a phosphate binder, is a good idea. So we don't need to notify the healthcare provider. Clopidogrel, Plavix. Look at the platelet counts. Again, remember we said clopidogrel, your Plavix, your antiplatelet can cause thrombocytopenia. We know that the normal platelet level should be between 150,000 to 400,000, but you can see our platelet level has dropped to as low as 70,000. The dangerous adverse effect of clopidogrel, we need to notify the healthcare provider. But again, I'm going to look at all the other options. Magnesium sulfate for a client with magnesium level of 1.0. Mag reminds me of magnifying glass. And I know that if I use a magnifying glass, it's going to magnify things to 1.5 to 2.5 times the normal. It's going to magnify it from between 1.5 to 2.5 times the normal size of what that thing is. So again, that tells me my normal magnesium level. And again, if I see a low magnesium level here, giving the client magnesium sulfate is not a bad idea. Metformin for a client with glycosylated hemoglobin. Look at the glycosylated hemoglobin level, 11%. We know that a normal A1C level should be below 5.7. So if it's above 5.7 to 6.4, that's like pre-diabetes. That patient is like probably going to have diabetes. So it's in a pre-diabetic stage. So normal should be less than 5.7, 5.7 to 6.4, pre-diabetes. And if it's more than 6.5, it indicates diabetes. So my client has diabetes, and giving him glucophage or metformin is not a bad idea. We don't need to notify it. So number 2 would be our correct option. The risk management nurse is reviewing client records. Which nursing intervention could have contributed to a sentinel event and unanticipated event? Option 1, administering flumazanil to a client on lorazepam. Well, look at this AZE here. So that's how I remember it, AZE. You also have AZE here. So that's how I remember that flumazanil is an appropriate antidote for a benzodiazepine overdose. So again, I wouldn't be concerned. How about number 2? Giving insulin dextrose to a client with potassium level of 3.5. So again, I think of potassium, and I remember that I can get potassium from bananas and all of that. And again, bananas come in bunches of 3 fingers to 5 fingers. So that's how I remember my potassium level, 3 to 5. So most textbooks will say 3.5 to 5. And again, a potassium level of 7.2 is on the high side. My client has high hyperkalemia. And again, if I give him insulin, it's going to help push this excess potassium intracellularly. So it's going to help to lower the serum potassium by pushing it into the cell. And then the dextrose is actually given to prevent hypoglycemia. So again, that would not be a bad idea. We can give insulin with dextrose, and that will help to lower the potassium level. This is an appropriate action. How about giving warfarin to a client with an international normalized ratio of 6? Again, I said the I reminds me of 1, the N 2, the R 3. So I know the normal level should be 1. If you're on warfarin, the level should be 2 to 3. This client is at 6. So again, that's I will need to look at this because there's a risk of bleeding. Remember, the risk of bleeding increases as the INR level increases. So if the INR level is 3, we don't want to give him warfarin that could cause a sentinel event. So remember, we said warfarin is an anticoagulant. We'll give it for clients with atrial fibrillation, clients with deep venous thrombosis and pulmonary embolism, and clients with mechanical heart valve replacement surgery. And how about number 4? Giving our nitroprusside, which is a potent vasodilator, and we use it for hypertensive crisis. So again, this guy is in a hypertensive crisis with a blood pressure of 210 over 112. So again, that would be a good action. Let's look at our platelet inhibitors and our glycoprotein 2B3A receptor inhibitors. So again, examples would be your Immunosuppressant, eptifibatide, and our tirofiban. So our Immunosuppressant, eptifibatide, and our tirofiban. So these are examples of your platelet inhibitors. And what they do is that they inhibit platelet aggregation. And again, that increases bleeding risks. So for these clients, we want to monitor the client's blood count. Look at the blood pressure, because if there's a drop in the blood pressure, that could tell you your client might be bleeding. Look at the heart rate and the rhythm. Because if the client is breathing, look at the heart rate, you can get signals or indicators from the heart rate and the rhythm. You also want to watch out for signs of bleeding, like the petechia we talked about, the purpura, black tarry stools or melena. Look out for hematemesis, look out for bleeding gum in these clients who are on your platelet inhibitors like your Immunosuppressant, eptifibatide, and our tirofiban. The nurse cares for a client following a percutaneous coronary intervention via the right groin. So again, remember, with PCI or percutaneous coronary intervention, the coronary artery, maybe the left anterior descending artery is occluded. We want to carry out PCI where we go into the groin or to the femoral artery, pass a catheter, put a balloon there, inflate the balloon. It's going to widen the artery, open up the artery, and then we can put a stent, and that will help to reestablish blood flow to that occluded artery. So again, that's what we refer to by a PCI. And again, how do you know what we use PCI for? For clients who have myocardial infarction, because that's what causes an MI when there's an occlusion to the coronary vessel. And again, on your ECG with clients with myocardial infarction, what are you going to see? We're going to see ST segment elevation. So you're going to see ST segment elevation on your ECG. Okay, so that tells you your client has a myocardial infarction. The client received an IV infusion of Immunosuppressant during the procedure. Which action should the nurse implement? Select all and apply. Again, your Immunosuppressant will be a glycoprotein 2B3A receptor inhibitor. It will also include your eptifibatide, your tirofiban, and they are used as platelet inhibitors to prevent the occlusion of treated coronary arteries during a percutaneous coronary intervention prevention, and they also prevent acute ischemic complications. Again, we said they can cause serious bleeding, so we need to closely monitor the client for any bleeding, especially at the groin, puncture sites after the percutaneous coronary intervention. So again, would I need to assess invasive procedure sites for bleeding? Yes, we said they could cause bleeding, so we want to monitor these sites. We can also check hemoglobin and platelet counts. because we said the clients could also, that could also tell us if our client is bleeding. So we should check the client's baseline complete CBC. If this client is at risk for bleeding, we don't want to initiate a second large bore needle. So one IV line, so want to eliminate this. Place the client on continuous cardiac monitoring. Okay, so again, that would be good because if we place him on a continuous cardiac monitoring, we could place him on a continuous cardiac monitoring because this will give us, it will tell us if our client is bleeding because we could see his blood pressure, if he's hypotensive, we can see if his heart rate is fast, if he's tachycardic. We are looking out for changes in the heart rhythm. And again, we would need to report any black stools because those could be signs of bleeding to the healthcare provider.